All right, so today we're going to really dive deep into pharmacokinetics. This is basically how drugs move through your body.
Yeah.
Ever swallow a pill and kind of wonder, where does this thing even go and what even happens to it?
All right.
Well, we're going to break it all down using this chapter we have here on physiologic drug distribution and protein binding.
Oh, great.
Think of us as your guides on this little journey, right?
Yeah.
We're going to be exploring how these concepts actually directly impact a drug's adventure through your body.
It's a wild ride through the body,
Oh, yeah, for sure.
full of twists and turns.
Totally. And understanding can really, I think, empower you when it comes to, your health and stuff.
Definitely.
So first stop on our journey, the circulatory system.
Okay.
It's like this vast network of highways, almost, with your blood vessels. They're acting like the roads, right?
Yeah.
Constantly delivering these precious drug packages.
Like a 247 delivery service.
Yeah. And it's a super busy network, too.
It is. The source here mentions that the average person pumps about 5.5 liters of blood per minute.
Whoa, really?
Yeah, that's like refilling a large juice container every single minute, even when you're just chilling.
That's crazy to think about.
I know.
And that's just at rest. Imagine when you're exercising.
Oh, yeah.
Your heart rate goes up and your blood is just pumping so much faster.
Your cardiac output can actually increase 5, even 6-fold
Wow.
during exercise, which means more blood flowing, and that impacts how quickly a drug gets distributed throughout your body.
So it's not just some random road trip then, is it?
Nope.
There's like a method to all this madness.
Totally.
So this chapter highlights how factors like blood flow, tissue size, and drug affinity all kind of act like a navigation system almost.
Yeah.
Guiding that drug to its destination.
Absolutely. It's like each drug has this personalized itinerary.
Oh.
So some organs, like the kidneys and adrenal glands, they're major hubs with tons of traffic because they have high blood flow.
Right.
Drugs reach these places super quickly, like 95% distribution in under 2 minutes.
Whoa, that's like express delivery.
I know, it's crazy fast.
So what about areas that are more off the beaten path, though?
Yeah, so like fat tissue has lower blood flow.
Okay.
So drugs take a bit longer to get there, around 4 hours to reach that same 95% distribution.
Oh, that's a big difference. Okay, so blood flow's key.
For sure.
But then there's this idea of drug affinity. Like some tissues are just more attractive to certain drugs, which is pretty interesting.
Yeah, like some drugs have a favorite hangout spot in the body.
Oh, like that.
Yeah, for example, flutamide, it's an anti-androgen drug, accumulates in the prostate,
Okay.
reaching concentrations 20 times higher than what you'd find in your plasma.
Whoa, 20 times.
Yeah.
So does that mean if flutamide is so concentrated there that men who are taking it might experience more side effects in that area?
That's a great question.
Yeah.
And exactly the kind of critical thinking we want you to do as you listen.
Oh, cool.
So, yes, targeted accumulation like this can mean that lower doses are needed.
Oh, okay.
So it potentially minimizes side effects elsewhere.
Well, that's good.
But it could also mean a higher risk of localized side effects. It's all about carefully weighing the benefits and risks,
Yeah, for sure. That makes sense. And it really highlights why simply measuring drug levels in your blood doesn't always tell the whole story.
No, not at all.
Like where a drug goes and how much accumulates in specific tissues makes a huge difference in how effective it is.
Absolutely.
And understanding that can help you advocate for your own health too.
For sure.
So speaking of exclusive destinations, let's talk about the blood-brain barrier. It's like the VIP area of your body, right?
Yeah.
And not every drug gets past those velvet ropes.
Right. The blood-brain barrier is incredibly important.
Oh, yeah.
Acts as a protective shield for your brain.
Yeah.
Carefully controlling what substances can enter.
It's like a super strict bouncer, making sure only those with the right credentials get in.
Yeah, you got it.
And it accomplishes this incredible feat through its unique structure, right?
Yes, it's all about those tight junctions between cells, creating this tough lipid barrier that's difficult to penetrate.
Wow. But what about those drugs that do need to get into the brain? How do they make it past this fortress?
Well, some drugs are small enough to just squeeze through the tight junctions.
Okay.
Others might be able to hitch a ride on specific transporter proteins, almost like shuttles.
Oh, like a little shuttle bus?
Yeah, carrying them across the barrier.
So it's not just about size. It's about having the right key to unlock the door,
Yeah,
almost.
you got it. And there are even efflux transporters,
Okay.
like P-glycoprotein, which act like bouncers, but they're kicking certain drugs out of the brain.
Oh, so they're like the bouncers who are saying, all right, you've had enough. You got to go.
Eggs.
Okay, so this blood-brain barrier then is like a, a highly selective filter, ensuring that the brain's environment, you know, stays like stable
Right.
and protected.
Mm-hmm.
And I remember the chapter actually mentioned a really powerful example, jaundice and bilirubin sensitivity in newborns.
Oh, yeah, that's a good one. It's a stark reminder of how vital that blood-brain barrier is.
Right.
Because newborns' blood-brain barriers aren't fully developed yet, they're way more vulnerable to high levels of bilirubin, which can be toxic to brain cells.
Gosh, this all makes me wonder, why do some medications make you drowsy while others don't?
Oh, that's a great question.
Does the blood-brain barrier play a role in that?
It absolutely does. So medications that can cross that blood-brain barrier and affect your central nervous system are more likely to make you drowsy.
Oh, okay.
The ones that can't cross, well, they won't.
Yeah, so that makes sense. All right, so let's shift gears a bit.
Okay.
Ready to dive into another game-changing concept. All right, let's talk about drug binding. And get ready, because I have another analogy for you.
Uh-oh.
It's like musical chairs, but happening in your bloodstream.
All right, I'm intrigued. Tell me more about this musical chair scenario.
Okay, so imagine proteins, mainly albumin, as the chairs,
Okay.
and then drugs are the people vying for a seat.
Right.
But not every drug has the same, affinity for those seats.
Mm-hmm.
And there are only so many spots available, too.
So some drugs are like those eager players, always ready to grab a seat. They bind tightly to proteins.
Total cat.
And others are a bit more laid back, content to stand if there's no room.
Yeah, exactly. So some drugs, like warfarin, are super clingy.
Oh, yeah.
They bind really readily to proteins.
Mm-hmm.
But remember, only the free drug, the one that's not bound to a protein, can hop off the bus, so to speak, and actually interact with its target.
Yeah, that's a crucial point. The degree of protein binding directly impacts how much active drug is actually available to do its job.
Right.
It's like having a VIP pass,
Oh, yeah.
Only those unbound drugs get to go backstage and exert their effect.
Okay, so that makes sense.
Yeah.
But what happens when the bus gets crowded and another drug comes along wanting that same seat?
That's when things get really interesting.
Oh, yeah.
Yeah, we call that drug displacement.
Okay.
So one drug can essentially kick another off its protein binding site.
Whoa, seriously.
Yeah.
And that means, more free drug is suddenly circulated, more VIPs backstage.
Precisely. And that's where things can get a bit tricky. If a drug suddenly gets displaced, its free concentration can spike, leading to a stronger and maybe unexpected effect.
Okay.
It's like having this sudden influx of VIPs. Things can get a bit chaotic back there.
Yikes. So does that mean potential side effects then?
Yeah, it could.
The chapter mentioned warfarin again, I think, as an example.
Yeah, warfarin is a great example because it's highly protein bound. If another drug comes along and displaces it, that can lead to an increased risk of bleeding.
Oh, wow. That sounds a bit scary.
Yeah.
But I'm guessing doctors are aware of this, right?
Okay.
They wouldn't just randomly prescribe medications that could cause these kinds of interactions.
You're absolutely right. Doctors are very aware of these potential interactions. They carefully consider protein binding and drug displacement when prescribing medications, especially for drugs with a narrow therapeutic window.
Oh, okay. Can you explain what a narrow therapeutic window means? For those of us who might not be familiar with that term.
Of course. So a narrow therapeutic window means that the difference between a safe dose and a potentially toxic dose is small.
Okay.
So even a slight increase in that free drug concentration could push someone into the danger zone.
Oh, I see. So with warfarin, for example, a little extra free drug could mean more bleeding than intended.
Exactly. It's a very delicate balancing act.
Wow. And that's why it's crucial to be open and honest with your doctor about all the medications you're taking, right?
Oh, absolutely.
Even over-the-counter drugs and herbal supplements.
Same.
Even things that seem harmless can sometimes cause these unexpected interactions.
Exactly.
That's a great reminder. So we've talked about blood flow, tissue affinity, and protein binding. Is there anything else that can influence how a drug moves through the body?
Well, the source mentions that gender can actually play a role in drug distribution.
Oh, really?
Yeah, it turns out that the expression of certain transporter proteins, like that bouncer P-glycoprotein we talked about,
Right.
it can differ between men and women.
Yeah.
These proteins act like gatekeepers, you know,
Okay.
controlling how drugs move in and out of cells.
So if those gatekeepers are working differently, that could impact how a drug is distributed then.
Exactly. And this is just one example of how individual factors can influence pharmacokinetics. Age, genetics, disease states, all of these can play a role in how drugs are absorbed, distributed, metabolized, and eliminated.
So it's like each of us has our own unique pharmacokinetic fingerprint almost.
That's a perfect way to put it, and that's one reason why personalized medicine is becoming so important.
Yeah, I can see that.
We're moving away from that one-size-fits-all approach to drug
Yeah,
therapy
right,
and recognizing that what works for one person might not work for another.
right. Makes sense. So understanding these individual differences is crucial for doctors, when they're prescribing medications.
Absolutely. It's all about finding the right drug at the right dose for the right person.
Okay, so we've covered a lot of ground here, from the circulatory system to the blood-brain barrier to protein binding, even individual differences. But before we move on to the next stage of our pharmacokinetic journey, is there anything in particular that's like resonating with you about how drugs move and interact in the body?
What stands out to me is how all of these seemingly separate factors, blood flow, tissue affinity, protein binding, individual variations, they all work together like pieces of this complex puzzle
Yeah,
to determine a drug's fate in the body.
that's so cool.
And recognizing that each person is unique, it just adds another layer of complexity to it all.
I agree. It's fascinating. And it emphasizes the importance of understanding these basic principles, not just for doctors, but for everyone.
Yeah.
Because it empowers us to be more informed about our own health and to have more meaningful conversations with, our healthcare providers. Now, with all this in mind,
Yeah.
any questions from you, the listener, about what we've covered so far?
And after we address your questions, we can continue our drugs journey and explore what happens when it's time for it to exit the body, that process of elimination.
Oh, yeah, that'll be interesting to get to.
So we've talked about how drugs enter the body, navigate the bloodstream, interact with proteins.
Yeah.
Now let's shift our focus to the final act of a drug's journey,
Okay.
elimination.
Let's
Hence
do
the-
it.
It's like the grand finale after, an amazing performance.
Oh, I like that. Okay.
Yeah.
Elimination.
Mm-hmm.
So I'm guessing this is where our trusty circulatory system comes back into play,
Yeah.
acting like a waste disposal service,
Yeah.
right?
Exactly. The circulatory system plays a crucial role, but there are other key players involved too.
Okay.
Think of the liver as a hardworking detox center,
Oh, okay.
breaking down drugs into metabolites,
Right.
and the kidneys as efficient filters, removing those metabolites and waste products from the blood and sending them out with your urine.
So it's like a coordinated effort then.
It is.
But I'm curious, does protein binding have any impact on how quickly a drug gets eliminated?
It absolutely does.
Oh, really?
Yeah. So generally drugs that are highly protein bound, the ones that like to hold on to those bus seats,
Right.
they tend to stick around longer in the body.
Okay.
They're not as readily available to the liver and kidneys for processing.
So in a way, like being bound to proteins acts like a protective shield almost,
Yeah.
delaying that elimination process.
Precisely. It's like having a slow release mechanism built in.
Okay.
It can actually be beneficial in some cases, extending the drug's therapeutic effect.
Interesting. So it's not always a bad thing then for a drug to be bound to proteins?
Right. It depends on the specific drug and the desired effect.
Mm-hmm.
The source mentions cephalosporin antibiotics as an example.
Okay.
They're mainly eliminated by the kidneys and tend to have longer half-lives when they're highly protein-bound.
Okay, so protein binding can slow down elimination.
Yeah.
But I'm guessing there are exceptions to this rule.
You're always thinking critically.
Well,
Yes, there are exceptions.
okay.
Some drugs are actively secreted by the kidneys, even if they're bound to proteins.
Oh, wow.
Penicillin's a great example.
Okay.
It's extensively bound to proteins, but still manages to get eliminated pretty quickly because the kidneys actively pump it out.
It's amazing how the body has these intricate mechanisms for getting rid of substances that don't belong there.
It truly is.
Right.
And this leads us to another interesting concept,
Okay.
restrictive versus non-restrictive elimination.
Okay, I'm all ears. What's the difference?
Think of restrictive elimination as the standard route.
Okay.
Only the free, unbound drug is available for, processing and removal.
Right.
So protein binding acts as a bottleneck, slowing things down.
Okay.
Most drugs follow this pathway.
Right. And non-restrictive elimination.
Non-restrictive elimination is like having a fast pass at the amusement park.
Oh, okay.
So even if the drug is bound to proteins, it can still be eliminated efficiently.
Right.
That's less common. But morphine, metoprolol, and propranolol are examples of drugs that, bypass the bottleneck, so to speak.
So for those drugs, changes in protein binding wouldn't really impact their elimination as much.
Exactly.
Yeah.
It's because their elimination machinery can handle those fluctuations in free drug concentration and maintain a steady state.
I'm starting to see how all these pieces fit together now.
Yeah.
Protein binding, elimination pathways, individual variations.
Yeah.
It's like a beautifully choreographed dance, and each step influences the overall performance.
I love that analogy. It really captures that complexity and interconnectedness of pharmacokinetics.
And speaking of interconnectedness, I remember the source mentioned that conditions like liver disease or kidney disease can really throw a wrench into the whole process, right?
Absolutely. Conditions that affect the liver or kidneys can significantly impact drug elimination.
Oh, yeah.
Because those organs play such crucial roles in breaking down and removing drugs from the body.
Yeah.
It's like having a traffic jam at those crucial exit points.
Oh, so if those exits are blocked, then, drugs can build up in the body.
Right.
And potentially lead to toxicity.
Precisely. And that's why doctors need to be extra careful when prescribing medications for patients with liver or kidney problems.
Oh, yeah.
They might need to adjust doses or choose different drugs altogether to avoid these dangerous buildups.
That makes sense.
Yeah.
This deep dive has been a real eye-opening experience.
Yeah.
I had no idea how much complexity was involved in simply taking a medication.
It's truly remarkable how much is happening behind the scenes every time we swallow a pill.
I know, right?
And I think the key takeaway for you, the listener, is that understanding these basic principles, drug distribution, protein binding, elimination pathways,
Yeah.
can empower you to have more informed conversations with your healthcare providers.
Right.
And to be more active participants in your own health journey.
Absolutely. It's about moving away from that black box mentality and recognizing that medications aren't, magic bullets. They interact with our bodies in these intricate ways. And being informed about those interactions can help us navigate our health more effectively.
Well said.
Right.
And remember, the next time you take a medication, think about its incredible journey through your body.
Yeah.
From entry to elimination.
Yeah.
It's a fascinating story of molecular interactions and biological processes, all working together to maintain your health. Okay, so we talked about how drugs, enter the body.
Right.
Navigate the bloodstream, interact with all those proteins.
Yep.
Now let's shift our focus to the final, act of a drug's journey, elimination.
Elimination.
It's like the after party,
Okay.
after the big show.
Right.
So I'm guessing this is where our trusty circulatory system comes back into play, right? Acting kind of like a waste disposal service.
Right, exactly.
The circulatory system plays a crucial role, but there are other key players involved too.
Oh, okay. Who else is in on this?
Well, think of the liver as this hardworking detox center, right? Breaking down drugs into metabolites, and then the kidneys, they're like efficient filters, removing those metabolites and waste products from the blood and sending them out with your urine.
So it's a team effort.
It is a coordinated effort.
Okay, I see. But I'm curious, does protein binding have any impact on how quickly a drug gets eliminated?
It absolutely does.
Oh, wow, really?
Yeah. Generally, drugs that are highly protein bound, those that like to hold on to those bus seats, so to speak.
Right, yeah.
They tend to stick around a little longer in the body.
Oh, okay.
They're not as readily available to the liver and kidneys for processing, you see.
So in a way, being bound to proteins kind of acts as a protective shield almost.
Yeah.
Delaying that elimination process.
Precisely.
Wow.
It's like having this slow release mechanism just built in.
Okay.
Yeah, and it can actually be beneficial in some cases.
Oh, really?
Yeah, extending the drug's therapeutic effect.
Interesting. So it's not always a bad thing then for a drug to be like bound to proteins.
Right. It all depends on the specific drug and the desired effect.
Okay.
The source mentions cephalosporin antibiotics, for example.
Go.
They're mainly eliminated by the kidneys and tend to have longer half-lives when they're highly protein bound.
Okay, so protein binding can slow down elimination,
Yeah.
but I'm guessing there are exceptions to this rule too, right?
Yeah. You're really good at thinking critically, you know?
Well, I try.
There are definitely exceptions.
Oh, good.
Yeah, so some drugs are actively secreted by the kidneys, even if they're bound to proteins.
Oh, wow.
Penicillin's a great example.
Okay.
It's extensively bound to proteins, but still manages to get eliminated pretty quickly because the kidneys actively pump it out.
That's like, it's amazing how the body just has these intricate mechanisms for like getting rid of substances that don't belong there.
It really is a remarkable system.
Yeah.
And this actually leads us to another interesting concept.
Okay.
Restrictive versus non-restrictive elimination.
Okay, what's the difference?
Okay, so think of restrictive elimination as like the standard route, you know?
Okay.
Only the free, unbound drug is available for processing and removal.
Right.
So protein binding acts as this bottleneck, kind of slowing things down, and
Right.
and most drugs follow this pathway.
All right. And non-restrictive elimination. What's that like?
Well, non-restrictive elimination is like having a fast pass at the amusement park, you know?
Okay.
Even if the drug is bound to proteins, it can still be eliminated, like really efficiently.
Wow.
It's less common. But morphine, metoprolol, and propranolol are some examples of drugs that kind of bypass the bottleneck,
Okay.
so to speak.
So for those drugs, changes in protein binding wouldn't really impact their elimination as much.
Exactly,
Okay.
because their elimination machinery can handle the fluctuations in, free drug concentration and maintain that steady state.
I'm starting to like see how all these pieces fit together now.
Yeah.
Protein binding, elimination pathways, individual variations.
It all comes
It's like a beautifully choreographed dance almost. Each step influences like the overall performance.
I love that analogy. It really captures that complexity and interconnectedness of pharmacokinetics.
And speaking of interconnectedness, I remember the source mentioned that conditions like liver disease or kidney disease can really throw a wrench into this whole process.
Absolutely.
Right.
Conditions that affect the liver or the kidneys can significantly impact drug elimination
Oh, yeah.
because those organs play such, crucial roles in breaking down and removing drugs from the body.
Yeah, we were talking about that.
Right. It's like having a traffic jam at those crucial exit points.
So if those exits are blocked, then drugs can build up in the body
Yeah,
and potentially lead to toxicity.
exactly. And that's why doctors have to be super careful when prescribing medications for patients with liver or kidney problems.
Right.
They might need to adjust doses or choose different drugs altogether.
Right, to avoid those dangerous buildups.
Yeah, exactly.
This has been such an eye-opening deep dive.
Yeah.
I had no idea how much complexity was involved in simply taking a medication.
It's really remarkable, isn't it?
It is.
How much is happening behind the scenes every time we swallow a pill?
It's so true. And I think the key takeaway for you, the listener, is that understanding these basic principles,
Yes.
like drug distribution, protein binding, and, elimination pathways, can really empower you to have more informed conversations with your healthcare providers
For sure.
and to be more active participants in your own health journey.
Absolutely. It's about moving away from that black box mentality,
Right.
and recognizing that medications aren't just magic bullets.
Yeah.
They interact with our bodies in really, really intricate ways. And being informed about those interactions can help us navigate our health more effectively.
Absolutely. Well said.
And remember, next time you take a medication, think about its incredible journey through your body, from entry to elimination.
Yeah.
It's a fascinating story of molecular interactions,
Right.
biological processes
Yeah.
all working together to maintain your health.
It's amazing. And that's it for this deep dive into pharmacokinetics.
Hope you enjoyed the ride.
See you next time.